Hey there, Healthcare Experience Matters listeners. We have three panelists joining our show today. I'm going to introduce them, starting with our very own Katie Owens, who is the president and co founder here at the Healthcare Experience Foundation. We also have joining us today Kumar Subramaniam. He is the president and CEO of SafeTower. And we also are joined by Eileen Kasda, who is the vice president of patient safety with SafeTower. And I'm going to now flip this over to our own Katie Owens here, as she will lead most of this discussion. And take it away, Katie. Welcome back to the show.
Thanks, Casey. Oh my goodness, I'm so excited about this conversation today and have been looking forward to it. Kumar, Eileen, before we go any further, can you share really what I find your compelling professional backgrounds and experience, and tell us a little bit about your roles at SafeTower before we go any further?
Hi, Katie and Casey. Thank you so much for having us today. We are also so excited to be here. I am Eileen Kasda. I am one of the co-founders and inventors of SafeTower. I actually found my way into patient safety after having been a patient and wanting to make a difference in improving healthcare. I had worked for Johns Hopkins for nearly 20 years. Most of those I spent in patient safety. Most recently, I was the director of patient safety for the Armstrong Institute for patient safety and quality at Johns Hopkins. And out of an immense amount of frustration and wanting to make a difference in this space at an industry level, I'm now currently serving as the vice president of patient safety for SafeTower. And I'll hand it back to you, Kumar.
Thank you, Eileen. Katie, I've been at Hopkins now for 7 years before we had this opportunity to come and create SafeTower with Eileen and the rest of the gang. But I've been in healthcare in general for the past 22 years, and most of my time has been in technology and management functions, both in the payer and the provider space. Over the past 6 years or so, I've been keenly interested in making a difference in patients' lives, starting with population health management, and then since 2022, working with Eileen to get this company started in the patient safety space. Thank you again for having us.
Oh, so thrilled and honored that you both have taken the time. You know, as we pursue our work at Healthcare Experience Foundation, one of the constant things that we've recognized is that the old playbook doesn't apply today, and that is so apparent in our approach to patient safety, where I think we've all recognized through interactions with health systems and in the national data that we've slipped and we've lost some of the progress that we've made, or a fair amount of the progress that we've made over the last decade with patient safety. We also know it's among the top 3 key drivers nationally of workforce engagement, that employees and physicians feel that they work in an environment that prioritizes safety. So tell us about SafeTower. How did it come about? I just think that it aligns so beautifully, your work and your mission, to what we're seeing nationally in 2024.
Sure. So I'll kick us off. When I first started working in patient safety at Johns Hopkins, I started as an analyst. And it was my job to read and theme every single patient safety event report that came into the organization. My job was to code these and make sure that the right people were getting these reports. And for those of you that may not know what a patient safety event report looks like, it's often a free text narrative, a paragraph or a couple paragraphs about something that went wrong or could have gone wrong. And as an analyst, every day I would come in, I'd have 100 of these things to read, and then every day 100 new ones would come in. And I felt like I was spending all of my time reading and coding events and not actually spending that time designing and improving safer healthcare practices. And over the years, I created all sorts of workarounds with my team to try to do some of this work better. And finally, we ended up taking matters into our own hands and designing a tool that better supported collaboration and analytics for using such a valuable patient safety data source. I felt like when we read these event reports, we saw that every event was a story of both a patient as well as healthcare workers and opportunities for us to improve. So Hopkins ended up building its own solution, and that product has now been in use at Johns Hopkins for over 3 years, and we are starting to see some of the positive impacts on both safety, culture, and experience.
So when you mentioned something to me, Eileen, that I've observed a lot, as well as our coaching team, which is I, as an employee, observe something, there's something I'm concerned about, I move to report that incident in the system, or a physician, we hear this a lot with physicians and APPs, I take that, perceived risk to make that submission, and then I feel like nothing happens with it. And I know this is something that you have both been really committed to, and maybe you might share with our listeners how you really work to address that sense of I've submitted and I feel like nothing's happened to that important, critical piece of information or concern.
The idea of reporting a patient safety event is often a fairly miserable process for frontline staff. When they would actually go to report a patient safety concern, it would take them a long time. They would be asked to answer all sorts of questions that they may or may not actually understand. And then when they finally did submit, much like you're describing, these event reports felt like they went into a black hole. And what they didn't know is that there was actually someone behind the scenes, like me, reading these event reports and lots of other people trying to take action on these. I think this is where the tools that we had at our disposal were not set up in a way to support robust collaboration with the frontline staff, as well as those who were using this data to make improvements. And so what we have done in our approach is we've really tried to break down these silos in communication and really include the voice of the frontline, as well as the voice of patients and families in our approach to doing this.
I think that last part is so important in the sense that we firmly believe that patients are an integral part of the care team. And it's only when their voices are included in improvements related to safety that we can expect meaningful changes to occur, right? And where we are headed is exactly in that direction, where we're going to be injecting patients' voices into the safety narrative, if you will, with the idea that they can help investigations and augment the various peer review processes that occur.
Of course. Yeah, absolutely. You've got, what's that saying? Somewhere in the middle between two different versions of the story is the truth. And what I just think I've seen in your tool is how you've assimilated AI dashboarding, closed loop accountability systems to help really take those voices and drive sustainable change for the better.
We're also trying to do it in a very thoughtful way where we're not bombarding people with more information and noise that isn't valuable to them, but filtering it so that they get the information that they need to actually make a difference.
Yeah, and what we've seen is leaders actually wanting to use innovation in this space, but being scared to deal with these new technologies such as artificial intelligence. And we are taking a lot of trouble to separate out administrative artificial intelligence versus clinical artificial intelligence. The clinical artificial intelligence area is fraught with a lot of risk because you're dealing with patient care and making decisions about patients' outcomes. Whereas with administrative AI, as we call it, it's much more tolerable for organizations. And so when we kind of make that distinction, there is heightened interest in the work that we are doing.
I feel like it takes something that feels so big and complex, and you've really made it simple. And I think your word, Eileen, intentional about how to maximize the cognitive load of any given leader right now in managing all of those priorities. I'm wondering if you might be able to share some examples, because I know you have many, of the work you're involved in to enhance safety and create those safer environments so that more and more staff and physicians and providers can voice their concerns.
Sure. We are thinking about ourselves first and foremost as a patient safety company. The work that we're doing is really in the spirit of trying to improve safety practices, but we are also trying to do this through the use of innovative analytics and software tools which is what we believe organizations need to move the needle on some of these outcomes and ultimately improve both experiences of healthcare workers as well as patients and families. We began our journey by developing a patient safety event reporting software product. That solution that we use is innovative in that it uses machine learning, much like Kumar is describing, and advanced analytics to help leaders spot problems that they need to go after and take action to improve those. And we are now working on building out additional tools to better support organizations in actually fixing the problems that they identify. Finding them is not enough. We actually need to do something to improve the healthcare delivery.
Absolutely, that bias towards action. And I know we've talked about this in our conversations, especially as we're starting to look at advancing health equity, addressing inequities. I think one of the things that struck me about your conviction is the ability to de-aggregate information to really help leaders. In my words, you probably have better words, but be precise in where they address those gaps.
Yeah. I love that. I think some of what we had found in our previous tools is that we were spending so much time looking through mounds and mounds of data to try to find the signals, much like you're describing. Health equity concerns is one of them. And what we're trying to do now is use new data mining techniques to make it easy to see these signals in data. They've been there all the time. They've just been hidden, and our ability to act on them and use them has been limited.
A key design principle for us was to include all voices in the patient safety space. So what we mean by that is by allowing the individual frontline reporter to tell us what happened in their own words, with all of the subjectivity that goes with the emotion-laden process that it is, we don't strip it out, compared to others. We allow for everything to come in. And then we respect that voice, and we use machine learning algorithms to make sense of what is being said to us. Now, we don't do esoteric things like sentiment analysis, etc. yet, because we want to be unfiltered in how we analyze people's voices. And that eventually leads to a much more open architecture, an architecture that includes people where they are in their journey. And then that allows for a more nuanced understanding of events as opposed to reducing everything to structured data elements, if that makes sense.
Absolutely. And that's the same thing we're seeing in our, I'd say, newer generational approach to rounding, is that the days of the old checklist mentality and the audits are, how do we really empower the voices and learn from where people are at?
One of the other things we're trying to do is we are trying to help organizations make sure that they're interpreting their data the correct way. And this can be really hard to do with voluntary reported data, much like a complaint or grievance or a patient safety event report. And so it's really easy for organizations to draw the wrong conclusion around safety or experience if we're not thoughtful in the story that data is telling. And so we're trying to make it really easy for people to tease out what story is the data telling them, and then to be able to take some steps to validate that story and then draw their own conclusions around it.
Well, and I'm hot off of a site visit last week with an organization where the approach hasn't been the same as the one that you've adopted, and there's more of a perception of a culture of perfectionism that borders on punitive nature for errors. And I think one of the things I've always treasured in our conversations is how you focus on really the gift of learning and recognition. And maybe you might spend some time, because I know that's something that all quality teams are wrestling with, is this desire to be always safe, and how to also acknowledge the good that's happening and celebrate those learnings that we may not necessarily want to have, and they're critical for us to have.
That is such a fantastic point. The longer I've been in this space, I've learned that almost every healthcare worker came in to healthcare to help people. And so I think some of what we've seen in this space is that we are fighting what feels like a punitive culture working against us, where the culture of blame is very real. And we need to start breaking down some of these conversations and realizing that human errors are going to happen. We need to use just culture algorithms when thinking about our response to these events so that we can balance the rare occasion that there are at-risk behaviors happening with human error. But what I also find when I look through some of this data, embedded sometimes in what feels like tense conversations between staff and patients, is really at the end of the day broken care delivery systems that we could redesign and do better. And at the end of the day, I find this common parallel between patients and healthcare workers, and they both want us to just do better and design a better system.
So I'm thinking about recent conversations also with team members who have had a persistent concern, and they'll often say, well, I submitted an incident report. What guidance would you give to leaders to help team members who may have felt that they've submitted that, but to open up other lines of communication, or for staff that may have felt that they've done it but not heard anything and that concern persists, what they might say to their leader to help elevate those concerns?
This is a fantastic question. I think some of what we've struggled with in patient safety is the desire to be transparent while trying to balance the fact that often this data comes with very sensitive information in it and peer review privilege protections that vary in how transparent an organization can feel about it or can talk about their data. Some of what we have tried to do is be very thoughtful to create communication and feedback loops that are done in a way that don't compromise the peer review privilege protection on this data, but also support organizational learning. And some of what I've realized is that there are risks in not talking about these things. And I think it's time that we start having more of those conversations, that if these things live in black holes, or we only communicate back with one work area and we don't communicate across organizations, we're missing significant opportunities to improve care.
So I know oftentimes when we're working with chief quality officers, experience officers, patient safety officers, there's often a question around the interrelatedness and interdependency of safety, quality, and experience excellence. Can you share some of the conversations that you're having and how you're helping organizations create those bridges instead of, reinforcing silos?
That's a great question, Katie, because I was recently talking to the chief quality officer of a large hospital system, and what I heard him say very clearly is that there is a strong link between safety and quality. And the way he looks at it is that without safety, there can be no quality, right? And his organization is focused on reducing harmful events, for sure. But then in the process of doing that, also looking at specific events from a quality perspective, whether it is reducing unplanned readmissions or unplanned extensions of stay. These are all things that are closely connected. And in his view also, unless and until they include the patient's voice from a grievance and complaints perspective into the set of investigations that can come from reporting an event, reviewing an event, he didn't feel like we could make a lot of progress. And so we're happy to say that we're very aligned in how he's thinking about safety, quality, and the experience part. We're busy at work right now embedding and creating a new grievances and complaints experience module as part of our solution, where we'll be able to inject the patient's voice into the safety discussion.
To build off of some of what Kumar's saying, I think historically our software and analytic applications have been siloed in operations. And so we may look at something like a safety event report from the healthcare worker's perspective, and we may look at a complaint or grievance from the patient and family perspective. But I think the idea of looking at these two more in a triangulated way would allow us to derive more value and identify opportunities sooner.
That proactive approach upstream, development opportunities just feels like the ultimate goal of what you're trying to create, so that patients have safer experiences, team members have safer experiences, and feel safe contributing what they're experiencing. Thank you.
That's a great point. Improvements in safety cannot occur in a vacuum without providing people a psychologically safe space to work in. And we're hoping that our solution contributes to creating such an environment where people can thrive and patients can feel better.
And in an environment where healthcare workers are so stressed and drained right now, I think that we also need to do better for them, as well as the patients who seek us out at often the most vulnerable times in their lives.
Is there anything else we wanted to add to the conversation?
For our listeners, that in the blog for today's episode, you can take a look at more information from Safe Tower, as well as if anybody would like to follow up personally with either Eileen or Kumar, their contact information will be there as well.
All right. You've been listening to, we have Kumar Subramaniam. He's the president and CEO of Safe Tower, and Eileen Kasda, who is the vice president of patient safety with Safe Tower. You can learn more by visiting safetower.com. And of course, we've also had this discussion be led by Katie Owens, who is the president of the Healthcare Experience Foundation. You can visit healthcareexperience.org for more on that as well. We hope you join us again next week for a new episode of Healthcare Experience Matters. Thank you, panelists, for your time today.